Good morning and welcome to the Virtual Prostate Cancer Summit, brought to you in partnership with Northwestern University Feinberg School of Medicine. My name is Dr. Judd Mao from Duke University Medical Center in Durham, North Carolina, and you are tuned into a session called What Do Clinicians Struggle With in Managing CRPC, or castrate-resistant prostate cancer? I'm here today with Dr. Gary McVicker from Northwestern, and we're looking forward to a great program today. This is just the first in a series today over about 5 or 6 hours where we're going to explore a lot of the issues in advanced prostate cancer. And I'm really excited to say this is my third opportunity to work with Platform Q and my second opportunity to work with Dr. Schaefer and his colleagues from Northwestern. This has turned into a Northwestern Duke tradition, and we're hoping to continue this series as we move into 2013. Now, before we get started, I'd like to remind our audience that we will be taking questions throughout the presentation. You can send us your questions through the box in the lower left-hand side of your screen, and we're really excited to have this educational opportunity where folks can ask questions. We want to make this as interactive and as educational as possible for the listeners and learners out there. Now, Dr. McVicker is an assistant professor in medicine, hematology, oncology at Northwestern University Feinberg School of Medicine. Dr. McVicker completed his fellowship and residency at the University of Michigan Health System. Now, I'm a Penn Stater, so we won't hold that against you. His clinical interests include kidney cancer, bladder cancer, genitourinary malignancies, prostate cancer, and testicular cancer. Dr. McVicker, welcome to the program.
Thank you.
So we're going to go ahead and get started. And one of the key things that we want to do is do this in a case format where we introduce the topics in the form of a case. So let's get right into it. The key thing that I want to mention about today's program, this hour and moving into the rest of today, is the fact that we're going to be covering a plethora of new agents in advanced prostate cancer. It's been an exciting 2.5 years in advanced prostate cancer now, with 5 new FDA approvals in advanced prostate cancer, totally unprecedented. And so as you see here on the screen, we've had Sapulous LT, or Provenge, that was FDA approved in April of 2010, followed closely thereafter with Cabazitaxel, or Jevtana, which was approved in June of 2010. We've also have Denosumab for bone health that was approved in the fall of 2010. We have Abiraterone that was approved in 2011, and now Enzalutamide, MDV-3100, approved just recently in August of 2012. So it's an incredibly important time in advanced prostate cancer.
John, if I could add, there's also a radiopharmaceutical alpha-radin, or radium-223, which is also will probably be added to this list at some time in the near future. And there are other phase 3 trials that are ongoing that hopefully will also yield positive results. So hopefully this list will continue to expand.
And you know, it's great that we're working together, because I think now more than ever it's really necessary for urologists and medical oncologists
Correct.
To work together. And the other thing cool about this program with Duke and Northwestern is both institutions have really embraced the multidisciplinary concept. So again, excited to be working together with Dr. McVicker. I'll be representing the urology point of view, and he's going to be representing the medical oncology point of view. Now, let's start right off with an audience polling question. Again, we really want to gauge the learners out there and get a sense on your knowledge and understanding. So our first polling question, regarding new agents for use in CRPC, which statement is true? Sapulous LT is a novel immunotherapy that lowers PSA levels on an average by a factor of 4.5. Cabazitaxel is a novel radiopharmaceutical agent that does not cause bone marrow suppression. C, abiraterone acetate is best taken with meals. And D, Denosumab, 120 milligrams sub-Q monthly, is used to prevent skeletal-related events. So let's ask our audience which of those is the correct answer. while we're waiting for the responses, do you have any comments about this question?
Well, I think I know the correct answer. So hopefully through the course of today, if people don't know the correct answer, I mean, these are topics that we'll be covering throughout the day that by the end of the day or the end of these sessions, people will know these answers.
So I guess we'll just go ahead and give everybody the answer. The correct answer, drum roll, is D.
Correct.
So if you want to, would you like to just make a comment on this?
I can explain why. So Sophilis LT is a novel immunotherapy, but although it improves survival, has not been shown to affect PSA, at least in the far majority of patients. Cabazitaxel is not the radiopharmaceutical that's been in development. That would be radium-223. And then abiraterone actually should be taken on an empty stomach. Food can affect the absorption of that agent. So really the correct answer is denosumab, which is used for skeletal-related events, and it is indeed dosed monthly.
And I actually see our audience was right on target. The vast majority of the audience actually got that question correct. And for those, again, tuning in, there's going to be a session this afternoon with my Duke partner, Dr. Andy Armstrong, who's going to be going into more detail on denosumab and bone health. So let's go on then to the next slide. And so what I want to do now for the learners and the audience is use an illustrated case to talk about some of the new agents in advanced prostate cancer. So this particular gentleman, 64-year-old, previously healthy African-American male who presented to the emergency room with back pain. And at that time, the emergency room physician did a digital rectal exam and it was abnormal. So a PSA was drawn and it was 225. Now, one might think, oh my goodness, we just don't see patients like this anymore, but we actually do. And I would just maybe ask Dr. McVicker, do you ever see patients like this still showing up in Chicago?
Yeah, yes. I think that the thought is that these are men who present with advanced disease are really a small portion now with the advent of PSA. But I would say that we probably do see a few of these a month where men present with widely metastatic disease, even in the era of prostate cancer screening.
And I know, obviously, from being at Northwestern, Dr. Catalona is a big proponent of PSA testing, as I am as well. I think most urologists and oncologists, you know, we're in favor of, you know, judicious and proper use of PSA, because we don't want to go back to the bad old days when we had large numbers of patients like this showing up. Correct. But anyway, this is a gentleman, and again, still in North Carolina, we see a fair number of these patients, as this case. He ended up having a biopsy with his local urologist and had Gleason 8 disease on 4 of 6 cores. He had a metastatic workup, bone scan, which confirmed metastatic disease, and the CAT scan showed no organ involvement, but did have some adenopathy. So we clearly have a gentleman who has high risk M1 prostate cancer, and he certainly is going to require a multidisciplinary approach. Now, he initially was started on hormonal therapy with Degarelix, 240 milligrams sub-Q, which was the loading dose in the first month, followed by monthly injections of 80 milligrams. And after 1 month, his PSA had dropped nicely to about 25. We'll talk about this a little bit in a few minutes, where I'm going to kind of ask Dr. McVicker what his opinion is on this use of hormonal therapy. But before we get there, let's just complete the case. His PSA natored at 1.2 5 months after starting the androgen deprivation therapy, but unfortunately, he then started to have a rising PSA and progressive symptoms. And at this point in time, once he had early castrate-resistant prostate cancer, the clinicians involved started him on bone protective therapy with denosumab, 120 milligrams sub-Q monthly. And again, we're going to be talking about this concept in just a few minutes as we move on. So his PSA was now rising despite androgen deprivation therapy. Also, his testosterone level was less than 20, indicating he did have castrate levels of testosterone, at least by the traditional guidance of either less than 50 or less than 20. Now, also in the next session, Dr. Schaefer and Dr. McVicker are going to be talking about the Nccn Guidelines. And one of the things I'm sure they're going to talk about is this NCCN debate as to whether a castrate level of T is less than 50 or less than 20, but we'll save that for the next section. He got started on bicalutamide at a dose of 150 milligrams a day as an initial hormonal, secondary or tertiary hormonal manipulation for early castrate-resistant disease. And at this time, he had bone pain, but it was controlled just with nonsteroidals. So the patient now has minimally symptomatic metastatic castrate refractory prostate cancer. And the key teaching point there is that certainly this gentleman falls directly on label for Sipuleucel-T or Provenge. Now, his PSA continues to rise. It's now up to about 16, and he's offered and accepts Sipuleucel-T and receives this standard individualized immunotherapy over 4 to 5 weeks without any complications. And we'll talk about that in a bit too. I want to get Dr. McVicker's opinion on Sipuleucel-T. He has a period of time of about 6 months where he's doing well, and then he starts to have progression with a repeat bone scan showing progression and further symptoms. Chemotherapy is discussed with him at this time, and that would be right on target with what would be a standard offering, but the patient would like to try another hormonal manipulation. So at this point in time, again, this is a little bit in the past, he was offered abiraterone, and again, that would be off-label in the pre-chemotherapy setting, at least still circa November of 2012. But at this point in time when this patient was treated, his insurance company did not want to cover it in that off-label setting. And we can, again, we'll talk about that a little bit later. Now the patient has progressed and is requiring narcotics for his pain relief. And another teaching point that we want to make is that if Sipuleucel-T or Provenge had not been used earlier, and we would have waited until he had bone pain requiring narcotics, he would have passed the point of eligibility. In other words, that drug has to be used for asymptomatic or minimally symptomatic disease, but at this point he had narcotic type of bone pain, so he would have been ineligible. So at this point in time, docetaxel is offered at the standard dose and the patient accepts it, and we'll get Dr. McVicker's opinion about the various chemotherapies in a moment. He has a PSA decline. He makes it through 7 cycles before he has progression. Then he does get progression. He receives some spot radiation, external beam, and does well for a while. Again, Dr. McVicker, nicely, you brought up radium-223 a little bit earlier. I don't think we have much on that in this session, but I guess at this point in time he could have received that therapy.
Correct. I mean, if he had bone metastases and was symptomatic, that would be something to think about, yes.
So again, for the audience and the learners, in the sequencing, this may have been a point in time where radium-223 could have been administered, but obviously it was not available when this patient was treated. Then he had somewhat of a PSA response, but then his PSA started to rise, and now he was treated with abiraterone acetate on label in the post-chemotherapy setting, 250 milligrams given with 4 dope pills up to a dose of 1,000 milligrams with low-dose steroids, and we'll talk about that a little bit later. He responds for a period of time, up for about 7 months, which is quite respectable, and then he does get progression and offers and starts cabazitaxel with GCSF. So I think this particular case illustrates what we want to talk about for the remainder of this session on putting these new agents in the context of care. So with that in mind, and with this slide illustrating these new agents, I would just get your general opinion about this case, if you want to make any comments, Gary.
Well, I think it's a good illustration of the fact that now in prostate cancer, you know, previously we thought of this as a disease that we would control with hormonal therapy. When that started to fail, then maybe some additional hormonal manipulations. But really our only active agent that extended overall survival was docetaxel. So a pretty linear progression, right? So androgen deprivation therapy, and then chemotherapy, and then subsequent to that, really no proven agent that would help in terms of overall survival. So this is an exciting time in that now we have several agents that improve overall survival. And so now we have challenges in that how do we select an appropriate therapy for the appropriate patient? So I think that this, this case illustrates one particular feature, and that is that we're trying to reserve chemotherapy for patients that are symptomatic. And so classically in this disease, we would define someone as being symptomatic in that, as you pointed out, they had bone metastases and bone pain that required opioids to control that pain. I would argue that maybe someone whose disease was progressing more quickly, either radiographically, by PSA, maybe they were symptomatic in other ways, you know, weight loss, fatigue, that maybe those patients you might also think about moving towards chemotherapy as opposed to just thinking classically about bone pain. So you treated this patient, or this patient was treated with the addition of an anti-androgen to their initial degarelix as sort of a secondary maneuver with hormonal therapy. And I think many of us would do that, provided someone wasn't symptomatic, to try to delay chemotherapy as much as possible.
Well, that was I think that was an excellent answer, and we're going to delve into some of the specifics in a minute here. I'd like to poll the audience again and to focus our conversation a little bit further. So this particular audience polling question is this: regarding degarelix hormonal therapy, which statement is true? A, the drug is an LHRH agonist. B, this agent, like aberelix, is a pure LHRH antagonist. C, this agent causes a surge in serum T for up to 28 days after initial administration. And D, this drug is considered the optimum form of peripheral androgen blockade. So for our audience, let's test your knowledge on initial hormonal therapy for this particular case. And so, excellent. So it looks to me from the audience polling that we have in already, again, this technology is wonderful. We're instantaneously able to poll the audience all around the world. We find that 96% of the audience got this correct, and the correct answer is the agent, like aberelix, is a pure LHRH antagonist. And I'm going to go right to this next focused question on number one, hormonal therapy, is degarelix better? And maybe ask Dr. McVicker if you could just make any comments about this that you'd like.
Yeah, I think that degarelix is an option. I don't think that it is necessarily superior to LHRH agonists. I think one of its advantages are that antagonists do not cause a surge in testosterone. And so patients who that you would be initiating hormonal therapy on, that would be a concern. You kind of want to get their testosterone levels down low quickly because they're symptomatic. That this may be one way of achieving that. So I think in those situations it may be an advantage. But for most patients, I think it's an option, but not necessarily the option.
I tend to agree with you. I think for the urologists listening in, and their staff, there's advantages and disadvantages. The advantage of degarelix is, again, as Gary mentioned, it's a pure LHRH antagonist, and all the audience, virtually all the audience, got that right. And so it doesn't have the flare, doesn't have that surge that you see in the first 30 to 60 days, and it does certainly bring the PSA down and the testosterone down more quickly. In the phase 3 trial where it got FDA approval, it was shown to be equivalent to leuprolide acetate in the 1-month dose. As you see from this slide, some of the longer term data would suggest it may have a slight advantage over leuprolide acetate. However, in academic fairness, these secondary analyses were not necessarily pre-specified in the initial trial. However, in my opinion, it certainly makes sense for a case like this with far advanced metastatic disease, at least initially. The biggest disadvantage is the monthly dosing. And certainly in practice, I'm sure at Duke and Northwestern and other institutions, many times we will start with this agent. It's a good starter, and at some point we'll switch to the LHRH agonist, such as a longer acting, for example, Lupron depot at the 4 to 6 month dose for convenience factors. But I thought it was important, again, to at least talk about a slight difference between the agonist and the antagonist for the start of this program today. Now, question number 2, is it important to prevent skeletal related events, and which agent? And you see this headline about the differences between denosumab or zoledronic acid. And I do want to get Dr. McVicker's opinion here, but just again, for the audience, I think the key teaching point, and we certainly don't want to go into a long discussion about mechanism of action, but denosumab is a rank ligand inhibitor. It prevents the vicious cycle of bone breakdown in advanced cancers, not just prostate cancer, but it's approved in many cancers that have bone metastasis associated with them. And from a practical standpoint, we have 2 dosages of denosumab that are FDA approved. We have a dose of 120 milligrams sub-Q given monthly, and we have a dose of 60 milligrams given every 6 months. Now, the monthly dosing, trade name is Xgeva, and the 6-month lower dose is Prolia. And you see on this slide in yellow where these drugs are indicated. Now, I'd like to ask, one of the things that typically comes up at our tumor boards at Duke, and I'm sure maybe at your institution, is, you know, when the FDA approved denosumab, they obviously had the clinical trial results, which basically only tested it in castrate-resistant disease. Correct. But yet when the FDA approved it, they gave the clinician a little more leeway and basically told, FDA approved it in any guy basically who has bone metastasis. So the $64,000 question, in your practice, do you tend to pull the trigger for denosumab with a new M1 patient like this guy right from the get-go, or would you tend to hold off on it until the man becomes castrate resistant?
Yeah, I tend to, so I approach this in 2 ways. In terms of regular dosing of something to reduce skeletal-related events, in this case denosumab, I tend to reserve that for men who have bone metastases and who are castrate-resistant. We have been, with the advent of the Prolia or osteoporosis indication, we have been, for our earlier disease setting men, been checking DEXA scans and looking for osteopenia and osteoporosis. So being aggressive in terms of monitoring that, because that is a risk of, or side effect, if you will, of being on androgen deprivation therapy. So for men who are not castrate resistant, yes, we do use these, but we use them more in the osteopenia or osteoporosis indication, and we look to see whether or not they fit that based on DEXA scans.
And for the, again, for the urologists or their staff who are tuning into this program, we also have the indication for patients who have non-metastatic disease but who are on androgen deprivation therapy and who are at risk for bone loss.
Correct.
And there we would use the 60 milligrams sub-Q every 6 months, and the trade name for that is Prolia. So that's something that I want to make sure that the urologists are well educated on. but once the patient goes from non-metastatic to metastatic disease, then the on-label use would be the 120 milligrams monthly, which would be the Xgeva. And I agree 100% with what Dr. McVicker said. So moving on, well, this just, again, just to make sure we make the key educational point that FDA has approved denosumab at 60 milligrams twice yearly for the patient with prostate cancer who does not have bone metastasis, but who is on androgen deprivation therapy and at risk for bone loss. So I just wanted to make that point. Now, one of the fundamental questions of this whole program today, this hour moving into the NCCN Guidelines next session, and throughout the day, is the proper sequencing. And so here's the next polling question for the audience. Which is the best sequencing of agents in advanced prostate cancer, CRPC? Now, this is based on their current FDA on-label indication. So let's see how the audience does on this. So again, it looks like the audience, I'm seeing this live and seeing people push their buttons on their computer all around the place, and the results are changing by the second. It's very exciting. So we're going to cut it off here soon. It's still changing.
It's like the election.
It's like the, yeah, it's like we're getting warmed up for the election, yes. So actually, we're actually broadcasting today from beautiful downtown Chicago, Illinois, and near the Northwestern campus, and so I'm the visitor here, and we had early voting in North Carolina. I don't know. Do you have early voting?
Yes, there is early voting here in Chicago.
But I
Chicago,
promise
you vote early and vote often.
but no more political talk today. Okay, it looks like we have the answers, and although it's still changing a little bit. Interestingly, the correct answer. Let's go to this. Let's click the button here again. So it's locked on me here. Oh, there we go. So the actual correct answer is C, degarelix, bicalutamide, and Sapulous LT, and that was the order that we saw in this case. Now, interestingly, the majority of the audience said B, abiraterone, docetaxel, and Sapulous LT, and so again, we actually had more people tuning in who gave the answer B, and I was just asked Gary if you could comment on why B is not correct.
Well, B could be correct, but I think B is probably correct for a select number of patients. Currently, abiraterone does not have an indication in the pre-docetaxel setting. There is data to support its use there, and it may have that indication in the near future. Sapulous LT we sort of reserve for patients who, as you pointed out, are either asymptomatic or minimally symptomatic from their disease and really have a pretty good overall performance status. The trial that established its use did include a portion of patients who had been previously treated with docetaxel, but that's probably a minority of post-docetaxel patients that meet those criteria. So I think C is probably the better choice, and that would be suppressing testicular androgen production, going through a secondary hormonal manipulation, and then if patients remain asymptomatic, then thinking about Sapulous LT.
And that's great, and I agree. I think I can understand why some of the audience said B, and B might be a correct answer in a couple of months.
6 months from now.
Yeah, in a couple of months. But and we didn't mean to trick the audience on this. Again, circa November of 2012, we're gonna stick with C as the correct answer. So moving right on, and again, Dr. McVicker, we already touched on this. Where do we sequence abiraterone or Zytiga? And just again, for the audience, I'm just going to go through 1 or 2 slides and then ask Dr. McVicker to make a comment. actually, before we do that, we're going to get to that data in a minute. And then the other question, where does cabazitaxel or Jevtana fit in the era of these two new oral agents? So maybe I could just ask for your comments now on the sequencing question.
It's becoming difficult, right? Because as we pointed out, the options are changing. And I think many who take care of men, many physicians who take care of men with advanced prostate cancer would like to delay chemotherapy as much as possible. So we'd like to be using hormonal therapy for as long as we can. So currently, as I mentioned, abiraterone does not have an indication pre-chemotherapy, but there is data to suggest that it has an impact on the progression of the disease, maybe on overall survival pre-chemotherapy or pre-docetaxel. And I think a lot of us would like it to find a home there. I do use it pre-chemotherapy in some men.
And if I could just ask you to, for my education as a urologist, the process, if you circa now want to use it pre-chemotherapy, in general, at least in this region of the country, is it difficult to get insurance approval in the pre-chemo setting, and what's been your track record?
Yeah, so no, we haven't been able to get it covered for everybody. It seems like it's easier now than when the drug first became available. So it's more a hit or miss.
Okay.
And it seems like insurance companies or third-party payers are more in line for covering it if there's, and this would be in agreement with the NCCN guidelines, if there were a reason why chemotherapy or docetaxel wouldn't be appropriate. So either performance status or maybe there was something medically about a patient that chemotherapy would be a concern. So someone who was maybe having, someone with thrombocytopenia,
okay,
and because of significant marrow involvement, chemotherapy might be a little bit difficult to dose, so abiraterone may be an appropriate choice for those patients.
Do you find that patient preference plays into it at all?
Yes, yes, a lot. So a number of patients have strong feelings about this and also would want to delay chemotherapy as much as possible. So we have looked into abiraterone pre-docetaxel for patients who have refused docetaxel.
Well, we're going to get into a couple more questions here. Specifically regarding chemotherapy, let's just use this scenario where the patient may have already progressed after abiraterone and is now clearly on target for chemotherapy. How do you sequence the approved agents? And again, just for the learners, we have officially now 4 FDA-approved systemic chemotherapies. We've had obviously docetaxel, which used to be called Taxotere, and now it's generic. Mitoxantrone, which has been around, I guess, since about 1999. Estramustine, which has been around since I was a resident, which is an oral agent, and cabazitaxel. And I guess my first question is, just to not to put you on the spot, is do you ever use estramustine anymore in your practice, or mitoxantrone?
So probably more mitoxantrone than estramustine. Estramustine maybe if someone has been heavily pretreated. So more of a third, fourth line agent. If we were to think solely about chemotherapy, the data would support using docetaxel as a first choice. Docetaxel was superior to mitoxantrone in 2 randomized phase 3 trials. And so that established docetaxel in combination with prednisone as our frontline regimen. And then subsequent to that, really the only data that shows an improvement in overall survival post-docetaxel would be with cabazitaxel. So that is typically our second choice following docetaxel if we're going to proceed with chemotherapy. And then subsequent to that would be mitoxantrone, I think, as a third choice. Again, never been shown to improve overall survival, but certainly has palliative effects. So for patients who are symptomatic, that might be an appropriate choice post docetaxel and cabazitaxel.
One of the questions I want to ask you, we've had stage migration in all aspects of prostate cancer, and I know in the original trials where docetaxel was FDA approved, if I'm not mistaken, they tried to get patients through 10 cycles, at least in TAX 327, the goal was 10 cycles. Do you find now in your clinical practice, are patients more or less likely to be able to get through 10 cycles? And what percent of these guys actually can get through that full gauntlet of 10 cycles?
I would say probably about 20% of my patients may complete a full 10 cycles. So I'm not sure that one of the problems that you're highlighting is sort of when do we start and stop these treatments?
Right.
So not only is sequencing these agents going to be a problem, but also how we define whether or not someone's progressing on a treatment is still not entirely worked out. And so when do we declare an agent ineffective and move to a next agent is still a bit of a gray area. And so I'm not sure that my practice has changed in terms of how much docetaxel we're using. We're just using it later now, I think, with the advent of these hormonal agents.
You know, it's interesting. So, obviously I'm a urologist and I don't administer these chemotherapies, but I'm very blessed that I work in a multi-D clinic, and so I'm literally in clinic several times a week with Andy Armstrong and Dan George, who are my medical oncology colleagues at Duke, and I've learned from them that a lot of times, they'll use a PSA response in the first couple of cycles of docetaxel, and one of the key teaching points I learned is you can still have a bounce, so you don't want to give up on it too soon, and but yet Andy showed nicely that decline of PSA, ultimately that is predictive of survival. So, do you want to make a practical comment on that?
I think that with any of these agents, I would say, we sort of have to balance three things: the PSA, and to some degree radiologic imaging. And then the third, and probably equally as important, is clinically, what does this person, this man with this cancer, look like in front of you? So how is he handling the treatment? How is he symptomatically proceeding in terms of his disease course? So I have had patients where you get them started on docetaxel, you'd like that PSA to come down in half and have a quote PSA response, but it may still continue to climb, but their bone pain is much better, their overall energy is improved, so clinically they seem better. And so we have continued patients on the drug even though their PSA may not necessarily be parallel with what they overall are feeling. And I think there's a general feeling that you really have to sit on a treatment for a period of time to let it cook and take an effect, really on the order of maybe 3 months for some of these agents to see whether or not they're going to have an impact on someone's disease.
So let's move on just a little bit. I think clearly that, again, chemotherapy for prostate cancer, this is the economic impact in 2011, and one of the things that I'm excited about is the fact that we hopefully will now have the opportunity to continue to turn prostate cancer, even advanced prostate cancer, into a chronic disease where we use these agents in a sequence, try to use them smartly to improve the overall outcome for our patients. And I'd just like to to continue to just ask you a number of questions. We really didn't get a chance to cover the issue of abiraterone pre and post. One of the questions that came up on that multiple choice question is the issue of dosing Abi related to a person's on an empty stomach or a full stomach. And I was wondering if you can, again, for the audience, just make some comments on that.
This is an agent that men should be taking on an empty stomach. There is concern that with food, men can get an increase in levels of the drug significantly, and so there's a concern for toxicity in that case. So it is an agent that generally men should take on an empty stomach. Oftentimes we tell guys to take it late at night because you're just going to go to bed anyways,
right.
and you probably haven't eaten in the near future prior to dosing it then. So it's less of an impact. But yeah, you need to make sure that you're stressing to patients that this is a drug to be taken on an empty stomach.
Excellent. The other thing I wanted to mention is, we're looking for questions from the audience. Again, we would love to have questions that come in. I'm able to see them right here on the computer. And again, please type in any questions you have. We'll just continue to go here, but we really want to get some questions. And it looks like there's a question coming in right now that we want to address here. So one of the questions that came in is that now in the era of, as of a month or so ago, we have enzalutamide. Again, for the audience, gosh, this drug has been called a number of different things. It was first known widely as MDV-3100, which is a new oral anti-androgen. Then more recently, the generic name has been called enzalutamide, and then just very recently, when it got FDA approval, the trade name is Xtandi. So a question here comes in is, what about, where does that sequence? Right. And how do you make a determination between abiraterone or enzalutamide? Right.
So enzalutamide is another hormonal agent. It's different than abiraterone. It works by a different mechanism of action. So as you said, it directly inhibits the androgen receptor. Its name sounds like bicalutamide, flutamide, but it's really thought to be sort of a next generation inhibitor of the androgen receptor. And so it's thought not only to bind to the androgen receptor, preventing testosterone from activating, but also preventing the translocation of the receptor to the nucleus, preventing binding of the receptor to DNA. So it seems to have more activity than our prior anti-androgens. It was initially studied post-docetaxel and shown to improve overall survival. So that was recently approved based on those data. But the question is, after docetaxel, would you choose abiraterone or would you choose enzalutamide? And I think right now it's a bit of dealer's choice. We don't know really how to select the appropriate therapy for a particular patient. And these drugs have been tested independently of each other. So, going forward, with a combination of the two drugs, be superior than either one alone, not known. But their current indications are separate and post-docetaxel. An advantage to enzalutamide is that it doesn't require daily prednisone. So particularly for patients who've had complications from steroids or maybe a brittle diabetic, sort of depending on your clinical scenario, enzalutamide may be a better choice. Alternatively, you sort of have to think about side effect profiles of these two drugs. And enzalutamide, there were a few seizures in that trial. Unclear whether or not that was drug-related. Most of those patients had other circumstances which might explain those particular events. But a patient with a history of seizures or CNS disease, maybe enzalutamide might not be what you want to choose. So, and similarly with abiraterone, can retain fluid, and so someone with heart disease can raise blood pressure. Someone with medical problems where they'd be sensitive to those changes, maybe that's not an appropriate choice for them. So you sort of have to weigh the patient's other comorbidities in addition to just the drug itself.
I think for the urologist listening in or for urologic oncologists, certainly it's an exciting time because both abiraterone and enzalutamide are oral agents. And I think in particular, a lot of urologists believe that enzalutamide may be comparable, at least in safety profile, to bicalutamide, and certainly that will open up the door for urologists to prescribe the drug and work closely with medical oncologists in administering this drug in the future. Same with abiraterone. Question came in from the audience that always comes in these cases. Do you need to continue the LHRH agents when the patient is already castrate resistant? Maybe just a quick, quick answer, Gary, from that.
Yeah, I get that question a lot too. Yes, it's important that throughout this area that we're talking about, metastatic castration-resistant prostate cancer, that patients maintain testicular androgen production. So whether that's on an LHRH agonist or an LHRH antagonist, either or, but you want to maintain the testosterone levels as low as possible. It's really retrospective data that has sort of led to that, but we sort of think that from retrospective data that men who maintain low testosterone levels do better in terms of survival. But certainly these new hormonal agents have taught us that, they were initially studied in men where we didn't think that necessarily that testosterone or the androgen receptor was so important, but yet even in a post-docetaxel setting, affecting those targets with these new agents improve survival. So it shows that throughout the course of this disease that maintaining low testosterone and shutting down the androgen receptor is important.
Well, one final question. We're almost out of time in this session, and there will be another session coming up immediately after this. Again, this program is going on for the majority of today in different sessions. But a question came in asking if we were going to be able to cure prostate cancer with all these agents. And I do believe that, we're in a new era. Prostate cancer now, I think of more as a chronic disease, even advanced prostate cancer. And when I have patients with advanced disease, I can give them more hope and confidence than I could just more than 2 or 3 years ago. I think it's a stretch to say that we're going to cure advanced prostate cancer just yet, but I certainly believe that sequencing these drugs appropriately is definitely adding quality life time to our patients with advanced prostate cancer. So with that last comment, again, I'd like to thank Dr. Gary McVicker from here in Northwestern for doing a great job. We've really enjoyed your answers, and I've just really had a great time being here. Always love to be in Chicago, and looking forward to the rest of the weekend here as well. And we'd really like to also thank the following companies for their support of this important educational initiative. Abbott, Bayer Healthcare Pharmaceuticals, Algenta US, and then please remember to complete the quiz at the end of this session to secure your CME credits. We're again delighted that you were able to join us today. We hope you stay involved with the program for the rest of today. This is going to be a continuing series. We're delighted to do the first one in April with Northwestern. This is the second one, and we're hoping to do continuing programs in 2013. So on behalf of everyone, I'd like to again thank you. My name is Dr. Judd Mao from Duke University, and thank you for joining us this morning.